diplegia gait presented by Wendy and Sonal. Spastic diplegia is a form of cerebral palsy where it's a chronic neuromuscular condition with hypertonia or spasticity. High tightness in muscles of lower extremity, legs, hip, and pelvis, caused by brain damage that inhibits development of upper motor neuron function. So this impacts the motor cortex. Cerebral palsy affects basal ganglia in the cortical spinal tract, motor cortex, and cerebellum. Muscles are continuously in a permanent contraction mode where they cannot relax and become hypertonic. It includes spasticity on both sides and lower extremity and upper extremity sometimes. Gait exhibits narrow base of support, scraping the toe, hip tightness in adductors, which causes legs to cross the midline. Symptoms of spastic diplegia. The gait of a person with spastic diplegia cerebral palsy is typically characterized by crouched gait, toe walking, and flexed knees are the common attributes and can be corrected with proper treatment and gait analysis. Symptoms of spastic diplegia depends on the individual and the severity of patient's case. Common signs and symptoms includes muscle stiffness, that's called hypertonia, especially in lower limbs, muscle weakness or floppiness, hypertonia, especially in lower limbs, abnormal muscle tone, reflexes, motor development and coordination, permanently fixed or tight muscles, spasms and spastic movements or gestures, use of only upper limbs to move around instead of crawling with both limbs and legs, unsteady movement and poor balance, continual hunch sitting posture, and seizures walking.
There are several different classifications of the spastic diplegia gait. The first is the true equinus gait with the ankle in plantar flexion throughout the stance and the hips and knees extended. Type 2 is called a jump gait. That can be with or without a stiff knee. The jump gait pattern is very commonly seen in children with diplegia who have more proximal involvement with spasticity of the hamstrings and hip flexors in addition to calf spasticity. The ankle is in equinus, the knee and the hip are in flexion. There's an anterior pelvic tilt and increased lumbar lordosis. There is often a stiff knee because of the rectus femoris activity in the swing phase of the gait. Type 3 is called apparent equinus, again with or without a stiff knee. Equinus may gradually decrease as hip and knee flexion increase. Sagittal plane kinematics will show that the ankle has a normal range of dorsiflexion, but the hip and the knee are in excessive flexion throughout the stance phase of the gait. Type 4 is the crouch gait, with or without stiff knee gait, also called a scissor gait. Crouch gait is defined as an excessive dorsiflexion of the calcaneus at the hip in combination with excessive flexion at the knee and hip. The result is an unattractive, energy-expensive gait pattern.
Here is a demonstration for Caesar's gait where you see increased knee flexion at stance phase, less knee flexion in swing phase, increased plantar flexion in terminal stance, increased plantar flexion in loading response, increased movement in terminal stance, and legs are adducted with hypertone in hip adductors muscles.
Treatments for spastic diplegia. Each patient is treated differently, but the goal for all is to obtain the highest level of independence possible. Physical therapy can help to reduce spasticity, increase strength, teach proper functional motor patterns, and help increase balance and stability. Promote motor and developmental skills. There are various forms of physical therapy put into use by professionals, such as daily range of motion exercise, which works to prevent or delay contractures caused by spasticity and to maintain the mobility of joints and soft tissues. Hippotherapy, or horseback riding therapy, which helps improve muscle tone, range of motion, strength, coordination, and balance. In addition, there are many social and emotional benefits to this therapy. Kinesiotaping, or elastic therapeutic taping, which works to re-educate the muscles for stretching and strengthening. Aquatic therapy and electrical stimulation, which can be used to strengthen muscles and increase muscle size. Most children will have AFOs. Drugs are often prescribed to reduce muscle tension, including baclofen, dantrium, and diazepam. Botox can be injected directly into the muscles to ease spasticity. Surgical treatments can include muscle or tendon lengthening or even cutting to improve muscle function. Ankle bones can be fused to aid in ambulation, and in extreme cases, selective dorsal rhizotomy can be performed to selectively cut the abnormal sensory nerve rootlets. This surgery usually results in a permanent reduction of spasticity. These are our references.